Topic is how to set target intraocular pressure. I chose this topic because I am frequently asked this question from my fellows, from my residents, and my colleagues, ophthalmologists. So that's why I chose this topic for this presentation today. I will start the presentation with this case. A 50-year-old male who was referred for glaucoma assessment and further management. There was just a positive family history of glaucoma, but these are his findings. You can see the pressures are borderline, they are above the cup disc ratio, they are also abnormal. The nerve fiber layer and the visual field defects, they are already there. So these were his visual field defects, and these are his OCT findings. So I think the diagnosis is quite simple. It is glaucoma on the both sides, but on the right side it is moderate primary open angle glaucoma, and on the left side it is advanced primary open angle glaucoma. Now the questions to be answered before we start treatment of this patient is, number one, is it relevant to assess target IOP for our patients in clinical practice? Number two, if it is relevant, then what are the factors which needs to be assessed? Number three, how to practically calculate this target intraocular pressure? And the last question, which is that what are the limitations when we are calculating the target intraocular pressure? Coming to my first question, and I will ask all the audience here that just answer me yes and no. If you say yes, please raise your hand. Is it relevant to assess target intraocular pressure? How many of you say yes? So less than 50%, they say yes. So it is absolutely yes, because the current guidelines in EGS of 2020, they have recommended to calculate target intraocular pressure for each of the glaucoma patient. And what is target IOP? It is the upper limit of the stable range of measured IOPs where the further optic nerve damage is retarded. Now, American Academy of Ophthalmology and European Society, they have defined target IOP differently, but the main aim is the same. They have the same objectives. Like American Academy, they define it as the upper limit of range of measured IOP, which is adequate to stop progressive pressure-induced injury of the optic nerve. And European Society, they say that it is the upper limit of mean IOP to slow the rate of visual field deterioration sufficient to maintain the patient's quality of life. Now, European Society, they have added the patient's quality of life. This is very important concept, what is quality of life, which is a huge topic, and they have incorporated this quality of life in the target IOP as well. And what are the evidences that they say that there should be always target IOP? We know that there are a few landmark studies like OATS study, normal tension glaucoma study, the SIGID study. They all were designed with predetermined target IOP, and they all have shown promising results. And the research has found it that they are very useful if you calculate target IOP. So the question, the answer to that question is that yes, we should calculate target IOP. Now, second, if target IOP is relevant, then what are the factors which needs to be assessed? So it can be classified in two ways. For new patients, the target IOP calculation is different, and for the follow-up patient, it is different. In new cases, we should always look what was the baseline IOP, which is also called the Tmax. It shows that at what level of the IOP the actual damage has occurred. It gives you the idea what was the pressure which has occurred that damage. Now, same is true for the baseline visual field defects. If you have a new patient and he has advanced glaucomatous damage, then you should always aim for lower target IOP. Same is very true for the optic nerve head damage. Thin CCT, the thinner CCT, if you encounter a patient with glaucoma who have thin CCT, we should aim for the lower target IOP. Then life expectancy. Now, life expectancy is very important. If younger individual of 40s and older individual of 60s, they have same glaucomatous damage, the target IOP for the younger is on the lower side as compared to the older one because of the longevity of life. Then quality of life. We should always balance We should not aim too high for target IOP that it jeopardizes the quality of life of this patient. Then it is sustainable cost. It is another important concept that the glaucoma treatment, it is lifelong, and this treatment should be at such cost that can be sustained. The other factors, family history of glaucoma, monocular patients, and pseudoexfoliation. In these patients, we also go for lower target IOPs. But in follow-up cases, we always look for the rate of the structure and functional damage. What we do in structure and function, it is disc assessment, nerve fiber layer assessment, visual field, and ganglion cell complex. So if there is any damage occurring despite you have achieved the target IOP, it means that this target IOP is not suitable for this patient. So we aim further to lower the target IOP. Then again, quality of the life. If the quality of life is miserable and our target IOP is achieved, we can aim for higher target IOP so that we can improve the quality of life of our patient. Then the side effects of the therapy. These are also very important in follow-up cases. The third question, which is actually what residents ask the most, how practically you calculate the target IOP? So the American Academy practice patterns, what they have suggested is that you stage the glaucoma in different categories, mild, moderate, and severe, and then normal tension and ocular hypertension glaucoma. So they suggested that for mild damage, for normal tension glaucoma, you should aim for 30% reduction from the baseline. And advanced damage, it should be 40%, and ocular hypertension, it should be 20%. But the problem with this is that if a patient has advanced glaucoma and the pressure is 40, if you aim for 40% of reduction or even 50% of reduction, it comes down to 20 millimeter of mercury, which is not sufficient. It should be much lower than that. Therefore, there are other guidelines, like Canadian guidelines. I follow these guidelines, the Canadian guidelines. What they have done, they have simply categorized or staged the disease like suspect, early, moderate, and advanced. And then they have given the reduction and target IOP for each of the patient. They have mentioned, like in early, moderate, and advanced, they have said in early that it should be 20 millimeter of mercury with at least 20%, 25% reduction. It means the 20 and 25%, they should go simultaneously. Same in advanced, it should be either 14 millimeter mercury, but with at least 30% reduction from the baseline. So this is another guideline. These are the latest guidelines from the EGS, European Glaucoma Society. Is almost the same like Canadian guidelines. Now coming to our case. We diagnose our case as primary open-angle glaucoma. Right is moderate and left is advanced. So this should be the target IOP for our patient. Now coming to the last question, what are our limitations in assessing target IOP? In daily life, there are few. Number one, target IOP is not a magic number. It is a concept. We should also all have this concept of target IOP. There are a few confounders of IOP. We know what are the confounders of IOP. IOP is dynamic. There are fluctuations, ultra short, short, and long-term fluctuations. There is risk versus benefit and quality of life. These issues are there. And there is another new concept of translaminar pressure. We are just working on the transcorneal pressure, but there is another pressure which is called translaminar pressure. Now take home message. These are from the WGA, World Glaucoma Association consensus. What they have said is that there is no single validated algorithm which is available for target IOP calculation. However, it does not negate its use. The use of target IOP in glaucoma requires periodic reevaluation. We have to adjust it periodically. And the burdens and risks of the therapy should be balanced against the risk of the disease progression. I would like to acknowledge British Pakistani Ophthalmology Society and Ophthalmology Society of Pakistan Federal Branch for inviting me for this presentation. Thank you, everyone.